If you distill the fundamental idea of healthcare down to its purest, most unadulterated form, the essence of it just seems so simple. When someone is sick, they should get the care that they need. And this should be true for all of us humans living right now, forever on the cutting edge of the future, riding around on this blue and green orb through the universe and living our shared history as a species. But there's a heartbreaking reality to healthcare, and cancer in particular. The messy and upsetting truth is that the number of people who can get the best care, if we can even agree on what that means, which we can't, is fractional. Untold numbers of people can't even get decent care, and millions of people get absolutely no care at all. So why is that? There are glaring, enormous problems plaguing medicine and medical systems around the world. How do we unwind them? How do we even understand them? And for all the individuals in the world with cancer who are struggling, how can we bring them within reach? Can we create actionable solutions that alter the course of their disease and of their lives? It's a lofty goal, but it's the one we're going to tackle right here. I'm Evan Young, and this is Within Reach from Avalier Health. John Sanders was 11 years old, playing basketball with his friends in the rural town of Estill, South Carolina, when two sisters from the Pentecostal church, the ones who'd been eyeballing him from the church's stoop across the street, offered him some orange pineapple Kool-Aid, which of course he accepted. I mean, hot summer day, basketball courts, who's going to say no to Kool-Aid? The sisters had noticed that John was just a bit unlike the other kids on the courts. He didn't swear. You should come check out the church, they told him. And a lifetime of John's devotion to God and faith was born in that moment, in the community he grew up in. A very long time later, with John as a much older man, it was faith and community that he would come to rely on. John had government clearance. He worked at Savannah River Site, one of the nation's nuclear security administration facilities, as a manager. But he was extremely sick, and months of treatment for a misdiagnosed ulcer was doing nothing to help him feel better. He'd lost weight, he was severely jaundiced, he had GI issues, and his urine was the color of, in his words, Coca-Cola. On his brother's advice, John saw an internal medicine specialist and got his actual diagnosis. He had stage 2 pancreatic cancer, but he was told he'd need to be filleted like a fish, cut open so pieces of all kinds of things, his intestine, his gallbladder, could be taken out. Of course, this scared him. Lord, if you don't lead me and guide me, I will not make it, he prayed. Where should I go and what should I do? This was his question to God. And, he says, God answered him. Duke Cancer Center. So that's where he went, for a much less invasive and successful laparoscopic surgery. But Duke was 6 hours away, and for follow-up chemo every 2 weeks, it wasn't feasible to stick with Duke. He'd be too sick to make the drive and wanted to be closer to his friends, to his family, to his support network of people at his church. So he shifted to be closer to home and put his care in the hands of Augusta Oncology, a community oncology practice. He'd be getting his infusions 15 minutes away. He could come home and sleep. And even though he was suffering, he'd be surrounded by a daughter to make him smoothies, friends to bring him freshly made soup, and his German shepherd Simba to lean on. The treatment he got from Augusta and how it enabled him to be surrounded by the love and care of his community was a godsend to John. On today's episode of Within Reach, I sit down with Ted Okon, Executive Director of the Community Oncology Alliance, and Maddi Davidson, Managing Director of U.S. Market Access at Avalier Health. And we talk about one of the hottest button topics in the U.S. healthcare system, the consolidation of care away from a community-based model and toward a large hospital system-focused model, and the impact that this shift is having on all of us. That's coming up next on Within Reach. Ted, Maddi, thank you so much for joining me today. I'm really excited to have this conversation about community oncology, what some of the issues are that we're facing there. First, I'd like to kind of just start off by doing something a little bit differently on the show. Ted, I'm going to start with this question for you then. And it's not a question so much as it's a little bit more of a role play. I would love for you to imagine me as a patient. Perhaps I've been diagnosed with some kind of a cancer, or even I've now been diagnosed with a cancer that's gone metastatic. And I say, doctor, I'm a lot more comfortable now going to a hospital that's 90 minutes away It's downtown, but I see their billboards and I see their commercials, and I really think that I'm just going to get a better kind of care or kind of treatment that I know that they can provide. So thank you very much, but I think I'm going to be going there from now on. So what would your response be to something like that?
Our response would be really simple. If you want the highest quality care that is also the most affordable and close to home, not that 90 minutes drive into the city, then basically you want to be at your community oncology practice. We have data that shows that the quality is not only the same, but in many cases is higher in terms of outcomes. And certainly it is much more affordable than what you would pay in the hospital setting. And again, it's close to home. And one of the most important things is when you're talking about high quality, affordable care, and then you basically can say it's close to home so that you're closer to where you live with your family and friends. That does it all. So I think it's really simple: quality, affordability, and accessibility.
That's great. And I love that framework because it gives us a couple of really distinct subjects to dig into. And I think the first one I'd like to hear a lot more about is the affordability angle. If you could parse that out for all of us, how is it that care could be more affordable?
So if you basically look at who's paying for the care, Medicare is the big payer because a lot of people are over 65, or it's basically a commercial player. So basically something that you pay for on your own or through your employer. And study after study after study, I'm not talking about one or two studies, basically shows that whether it's Medicare paying or whether it's on the commercial side and insurer, that the cost to you in an independent community oncology practice, meaning run by a physician, is going to be a lot less than in the hospital setting. For example, on the Medicare side, when you look at, let's say, the first hour of chemotherapy administration, so getting chemotherapy, it is a lot more expensive and hospitals are paid a lot more. Therefore, you have a lot more cost in the hospital setting than in the independent community oncology setting. When you go over to the commercial side, it's a huge difference. And what I say, Evan, happens over and over and over again as we've seen some consolidation, meaning that a community oncology practice is bought by a hospital. I've seen patients who are, let's say, in their third cycle of chemotherapy. And now they're going into the same building with the same name because they haven't changed it, but it's been acquired by the hospital. The same nurse is administering the same chemotherapy. You're seeing the same doctor, and patients get their bill and they're startled by the cost they're paying. Nothing has changed. The only thing that's changed is the hospital has acquired the practice. And that's why you see costs in this country go up so much, because not just in oncology, but in other areas of medicine, practices, independent community practices, have been bought up by hospitals, and hospitals charge a lot more.
So, Maddie, I have an emotional and a logical reaction to that, but I'll give you a chance to weigh in on either of those components. What do you think?
I think it's interesting when we look at why these hospitals are coming in and what is the driver of the community oncology practice willingness to sell. To Ted's point, it's not only that care costs less, but they're reimbursed less for the same services. So community oncology practices have faced this building, ongoing, sustained financial pressure for decades. And it continues. And, every once in a while, there's a congressional fix to increase payment, but it is always less than the hospital setting for the same services. And that will continue to build. So, right, it's a financial pressure to, maybe the hospital in your area is your only option to stay open at all. Interestingly, I think, Ted, something that we hear a lot of, and curious your thoughts here, is like we also see private equity come in as an alternative to hospital. And some may argue, well, when private equity comes in, the costs also go up. But when you look at the cost of private equity acquisition on average relative to hospital, that cost is lower still. So even though the practices can remain independent and they get financial support from private equity, the cost may go up relative to what it was before, but it's still less than a hospital.
Hospitals now are required to provide their own data in a format that you can basically compare one hospital versus another, or even a hospital versus a community setting. So you can pull that data. We have pulled that data for a certain element of hospitals over 1,000. And we've looked at what do they actually charge for oncology drugs, cancer drugs, above the acquisition cost, what they purchased those drugs for. And it's stunning that on average, for all of these hospitals, it's 3.8 times more than what they purchased these drugs for. So it just shows you as hospitals have consolidated in this country and become mega health systems, they literally charge more. So when you look at the drivers of cost in this country, it's hospitals, especially when you compare that to, in our case, independent community oncology practices.
So if I'm the hospital, what is the reasoning that you're hearing? Is it, hey, we have X amount of overhead to cover, or is it profit? Is it something else that's driving that 3.8 times more expense?
There is literally a war going on now between hospitals, especially these mega health systems that have consolidated, and the insurance companies that have consolidated as well too. The insurance companies try to use their leverage with the hospitals. The hospitals get bigger to use their leverage with the insurance company. So in the process, it's the patient who loses because the hospital that can charge will charge a lot more simply because they can do it.
So leaving aside outcomes, I think, what is the end result on the players in the community oncology care settings? Is it that they're driven out of business? Do they give up? Is there attrition there?
So 20 years ago, 84% of the cancer care in this country was delivered in the independent oncology setting. Physician run, physician owned, not hospital run and hospital owned. And the remaining 16% was in the hospital setting. That's now about 55% delivered in the independent community oncology setting and the rest of the 45% in the hospital setting, because hospitals have literally merged or bought up physician practices to the extent that they can, because there are a lot of advantages for nonprofit hospitals that have nonprofit breaks, as well as the ability to purchase deeply discounted drugs, so that when you buy an oncology practice, and remember, you can charge more even for things like the first hour of chemotherapy administration. I'm just taking that as an example. So when you buy a practice, that oncologist, depending on what she or he basically what types of cancer they treat, they can represent anywhere from $6 to $10 million worth of, in essence, profit to that nonprofit hospital. So it's very, very advantageous for a hospital system to try to put as much pressure on to buy up a practice. And you have to understand that these independent practices are on a lot of pressure, not just by the hospital, but by the insurance company, by the federal government. So that's why you've seen a lot of the cancer care shift from the independent community oncology setting to the hospital setting.
Ted, so that stat, the 55-45, is that based on patients receiving active treatment?
Yeah, Maddie, it's basically a round number in terms of contrasting the 84% down to the 55%. You still have oncology practices merging, trying to survive, as you said, actually using private equity to try to survive. So, you've seen a little bump up there, but still it's a big contrast between 20 years ago having 84% in the independent setting and now 55% of the cancer care administered there.
So, Evan, we just did an analysis with COA looking at Medicare fee-for-service claims as well as Medicare Advantage encounter data, where we were looking at where care was delivered. And we found that 55-45 in terms of our sample for chemo or oncolytic administration. But when we looked at just the overall population of patients with cancer types we included, We saw a huge discrepancy. If you look at the number of oncology sites between community and hospital in the US, about 36% of sites are community oncology sites, but they're treating 81% of our population. That's different from that 55 number because this is including patients on active treatment, whether that be infusion or orals, as well as ongoing surveillance. Right. So to me, that says like keep patients in the community so they can receive the care they need. If that care goes away, are you going to end up diagnosing patients later in their journey, which will result in worse outcomes? Are they less likely to get to their treatments on time? Patients with cancer need a lot of support. Is it even feasible for a family member or caregiver to take off work and get them to their treatments? Like these are all things that to me are so critical about keeping care in the community.
So, do you think if I were to have surveyed your average oncologist at ASCO a couple of weeks ago about the quality of care that they would receive that were in a hospital or a community care setting, what do you think that they would say about the quality of care? Is this a widely held belief that community care is better?
No, actually, I just got a text from somebody last week that was at a big meeting, and there were some big academic centers, and they were basically talking about the higher quality of care, especially in survivability. And the problem is they were comparing it to a small community hospital, not a community practice. And, some of the practices, I mean, Texas Oncology has 600 oncologists. You think, oh, MD Anderson, and that's the old be all? No, it's Texas Oncology or it's Florida Cancer Specialists with over 300, 400 physicians that does a lot of phase one research. But the academics have this perception that they are the best. And therefore, the interesting thing is those centers are running the commercials. How many commercials do you basically see from big academic centers? And I'm not just talking about where I am in North Carolina and seeing it from the University of North Carolina or a Duke or something like that. You see it from MD Anderson, and you see it from today. I saw a commercial from UPenn because cancer and treating cancer has become big business in this country, and it's worth their while to spend millions and millions of dollars advertising. So they always want to say, no, they have the highest quality. But I will tell you, at the Community Oncology Conference back in April, we presented phase one data of a quality study looking at community oncology practices versus the hospital practices that report through the SEER system. And in what we looked at, had higher quality. And we're going to be proceeding with phase two and phase three of that study as well, too, which shows quality. Everybody knows, and there's no debate, that literally the affordability, the cost in a big hospital academic center is a lot more. And there are reasons why they say that's a lot more. But the fact is, patients pay more. But they always go back and say, we have the highest quality. And it's just not the case. And the data is going to show that. And that's why we're finally looking at not just the cost of care, but the quality of care.
Well, I'm so glad you mentioned advertising and marketing because that's exactly where my brain was going to next. So, do you think that those independent centers are simply being outspent, or are they putting less into their own marketing? Secondary question to that, too, is that advertising and marketing, I think it's mostly, I would assume, being directed at patients rather than HCPs. But is there a knock on effect that the HCP is then seeing it? They see the same ads, they drive down the same highways, they watch the same shows. So, given this where the spend is, do you think that that's just collateral damage, so to speak?
Well, first of all, the big centers spend millions and millions of dollars, but the practices need to do as much. They need to tell their story. I mean, that's what happens. And the interesting thing is when you look at the employer market, when you look at the insurance market, you look at all of that, more and more, there is a realization that it isn't just about sort of this center of excellence, that a center of excellence may be a practice right there. And remember something too. When we talk about a independent community oncology practice, and you talk about it, like I said, a Texas Oncology, a Tennessee Oncology, a Florida Cancer Specialist, you're talking about literally hundreds of individual practices. So it may be a facility that has 2 or 3 docs that is part of this bigger practice. That's the whole idea of having literally a facility that you can go that's close to home, that's 10 minutes away, and you're not driving 2 hours away. That's the beauty of independent community oncology. You have the centralness, if you will, of the quality of care, physicians sharing information, up to date standard of care treatments and guidelines, but in a much more affordable setting that's close to home. And I will tell you, especially being married to an oncology nurse, that having that local care close to home where you have family and friends, boy, is so important.
So if we're looking at the percentage of Medicare beneficiaries who had to travel 5 miles or less to reach their nearest treatment option, about 90% of beneficiaries could travel 5 miles or less to reach their nearest community oncology practice versus about 15% in terms of a nearest hospital-based practice. So it's keeping care closer to home.
Well, we're talking about profit, and profit ultimately goes to individuals. So, Maddie, I wasn't expecting to be talking about private equity in the show here today, but you mentioned private equity not too long ago. Can you go back to that? Because I think that's interesting. It seems related to what we're talking about.
Yeah, certainly. So there has been in the past several years more investment of private equity in healthcare in certain specialty areas, oncology being one of them. The idea there is that, if you're a practice that is financially at risk, maybe, or not, they might go into it for other reasons, but there is an influx of cash from private equity investment. Those investors are obviously looking on a return on investment. If we're comparing and contrasting, there's still that for-profit mindset there. I think the difference is that a lot of these deals, they are still managed and at least partially, if not majority, owned by the physician still. So you still have the physician voice, physician ownership, leadership that is driving the day-to-day patient care and how they operate. And to me, that's the difference between what Ted was explaining between some of these corporate entity engines that have become some of the hospital systems and what a private equity backed community practice may see. And I think it works differently for different practices. And we've seen, investment come in and out, but ultimately these practices, the stories they've shared is that they maintained ownership, direction, patient advocacy services, et cetera, to really stay community focused.
It sounds like then private equity is just a piece of the hospital system puzzle, but it's not the only piece. Is that about right?
Yeah.
Yeah, interesting. So, Ted, there's a famous little bit in The Simpsons, right, where Homer takes a look at the morning paper and it's got old man yells at cloud on there. I'm mentioning that because you'd said something about like, hey, we've kind of lost our way and maybe we can get back to a time when community care really was a bit more in the driver's seat. What's the rebuttal to that? What are some of the objections that you feel like you might hear?
Well, I would say that basically the hospitals will tell you that they need to merge, they need to grow bigger because the insurers are. And so the only way they're going to have leverage over the insurers is to grow bigger. And the insurers will tell you basically the same thing as well too. There's one inescapable conclusion here that as we've seen more mergers among hospitals, as we've seen more mergers among insurers, healthcare costs in this country are exploding. They're not going down. So when the hospitals say that we're trying to rein in costs, or the insurers say we're trying to rein in costs, the bottom line is that's not borne out in the data. The data shows that we have higher costs. The costs are exploding in this country, healthcare costs. And more, you see not only articles about patients and referring the data, but you see studies that have come out that have proven that and have shown that. And frankly, 5, 6 years ago, Evan, you would not see the extent in the press about hospitals. They were more darling, they were the good guys. And now you see stories more and more about hospitals, again, like I said, that are making money hand over fist and are also at the same time aggressively debt collecting and going after patients. I mean, we've seen this again and again. So again, the hospitals will say, we need to get bigger to fight the insurers. The insurers say, we need to get bigger to fight the hospitals. So you have a vested interest in getting bigger and bigger and bigger, both on the hospital side as well as the insurer side. Look at the big insurers and look at basically what the top people make there. Unfortunately, we've shifted our focus in this country in healthcare from patients to profits. And again, I don't damn a lot of the people, especially in the hospital system, working there, but we have lost our way.
Yeah, I'll relate just a quick personal story. I mean, I know exactly what you're saying. I needed an x-ray a few years ago, something like that. I went to the local branch of my downtown urban hospital system here in Philadelphia, which I'm sure you would know. The negotiated rate for an x-ray was $352, and that's what I got billed because it was earlier in the year. And I remember being on the phone with the person just saying, what is this? This is an x-ray. You know, Marie Curie discovered x-ray technology in 1898. Why are you charging me $350 for this? It should be nothing almost. And, you know, that conversation went nowhere. And I think the point of what you're saying about aggressive bill collection, you don't really have much choice. Forget just personal responsibility and feel like, okay, you want to be somebody who pays their bills, but you certainly can't let it impact your credit. And I think when you start to put that on the table, I think that really is, it's really unfortunate.
It's tough. And you're lucky. You have an example that's actually a good example. I mean, I've seen examples in terms of x-rays and higher order PET scans that the hospital's charging thousands and thousands and thousands of dollars. And then someone compares it to a freestanding imaging center, physician run, or a practice. And it's literally just a small percentage of that as well too. I mean, again, you know, these aren't one-off examples. It's more prevalent because that's the way we are today. We're going bigger on the hospital side, we're going bigger on the insurer side.
So, Maddie, when we think about solutions, because this all sounds like it's tough not to feel deeply frustrated, it's tough not to feel a little bit hopeless. So, what are some of the solutions when we think about directions and places we can go?
I think one of the first steps has to be evidence generation and proving all these things to stakeholders, from policymakers to insurers to patients, just to make sure that they know you don't have to go to your far away AMC to get care. There might be something in your community that is closer, higher quality, and more affordable. But until those data are available, I think it's hard to prove that point consistently, which Ted talked about the quality study they did. We also just did this study looking at the claims data in terms of where is care being delivered. So I think continuing to share those data with the right people with the right message is core, which is COA's core purpose day to day. We talk a lot about site neutrality as well. So we talked about the same services being paid for at different rates. So one option there, increasing the rates in the community setting to be more equitable to other rates. And there's different places you can find money to do that, right? Because you don't want to just, we're talking about increasing healthcare costs. So you don't want to just keep increasing the costs, but it's like, where could the costs be redirected to find that solution is one way. There's also, we haven't even touched on IRA yet.
I did want to touch on IRA, and Maddie, I would love for you to figure out how to get us into the part of that conversation that is really relevant here.
So the Inflation Reduction Act, or IRA, is a larger piece of legislation with several components that impact healthcare. One of them being, which, as we talk about the financial pressures oncology practices face, is around drug price negotiation, which historically the federal government has not been able to negotiate prices that they pay for drugs. So through the IRA, this is the first time that this has happened. It impacts both the acquisition price of a drug that a provider pays, as well as the reimbursement rate those providers receive from the federal government. We're talking about Medicare specifically here. There's also a downstream impact that the reimbursement rate, or maximum fair price, MFP, that the government sets through this negotiation process will also impact commercial payers and the rates they will pay. So it's not only Medicare beneficiaries who are receiving these negotiated drugs, it's not only an impact on reimbursement for those drugs, it's also the commercial payers and their patients that are also impacted. So all of this layers up to a larger impact on the provider based on how the legislation has been interpreted and defined through legislation, guidance, and rulemaking. Ultimately, the provider, when we're talking about Part B as in boy price negotiation, is left in the middle. So the solution, they're focused on removing the provider from the middle of this process and putting the negotiation and the potential savings to the government, which is the goal of this negotiation, just between the manufacturer and the government.
It sounds great to use the power of the government to negotiate drug prices downward, but how you do that is really key. And how the government does that as part of the Inflation Reduction Act is, let's just take the case of a $2,000 cancer drug that the government negotiates downward to $1,000. And remember, for the most part, it's not really a true negotiation. It's the government using their power to say, based on all evidence, this drug should only cost $1,000. The problem is that it puts oncology practices in the middle of that negotiation. It creates a new payment rate based on that $1,000 discount downwards that impacts the oncology practice. Frankly, they're held hostage to this. And it creates all kind of operational problems as they're facing pressures as it is that are innumerable. And what it does is it creates a special payment rate that will actually knock down other payments. And the end result is it will put huge pressure on oncology practices. One of the things that we are trying to do is to literally get us out of the middle of that by having simply the drug manufacturer rebate the government that $1,000 difference without creating a new reimbursement rate. And the patient would pay off of the lesser $1,000. So the patient would be fine. The government would get its $1,000. And it would take us practices out of the middle of that in terms of being held hostage to this new payment system. And that is huge. So in the House of Representatives, Congressman Dr. Murphy has introduced a bill that would do exactly that. And in the Senate, we are waiting for Senator Barrasso introducing a look-alike bill, the same identical bill, that would again make everybody whole, but would not put pressure. You put pressure on oncology practices, you're going to push them into the hospital. And like we've talked about, the hospital is the higher cost setting, in some cases, not as quality. And literally, the patient may have to commute a lot more to get their care than their local care. So that's sort of in a nutshell.
So there's a second part, a different part of the IRA called the inflation rebate penalty that looks at how the price of drugs has increased over time. If that rate of increase is greater than the rate of inflation, then providers have to pay a rebate back to Medicare to cover that difference. If we're thinking about how would this change to Part B price negotiation and effectuation of that price be implemented, that is the relationship between there's already a rebate mechanism in place that's working for one aspect of the IRA. So the thought is also apply it to this aspect of the IRA.
So you had the government saying Medicare reimbursement, we would like you to lower those costs, get them down to X costs. This is what you're going to be reimbursed. And so that pressure downward, you're saying, is being applied more to the community.
Yes, how they do it, because it puts the practice in the middle of the negotiation between the government and the drug manufacturer. I'm in the middle of that. And the idea is to get out of the middle. And the idea of rebating meaning a drug manufacturer rebating that $1,000 in the exam. I just took a simple math example, is actually that rebate mechanism has been in place in the government for Medicaid forever. And it's actually part of the IRA. When the drug manufacturer exceeds the inflation rate, they have to rebate the government the difference between that inflation rate and basically where they put their drug. So the mechanism is in the IRA as it is. We're saying take the same mechanism and just get us out of the middle of that negotiation, because it creates an operational nightmare and a financial nightmare for the practice.
Traveler's done a lot of studies on what does this mean economically for practices. So one of the original analyses we did estimated that oncology practices over 5 years, of the sample of drugs we included, I think it was 4 or 5 drugs selected in the beginning of this program. So it didn't even account for what comes in subsequent years. It was 12 to 19 billion dollars of loss on add-on payment. And the critical thing is that add-on payment, or thinking about reimbursement for drugs, is it goes towards funding the practice operations, the staff, the storage, the administration, all those things that just because there's a new price of the drug, none of that changes. So to Ted's point, right, it's same cost, lower reimbursement, downward pressure. What happens to the practice? And then the solution that Ted talked about, right? It's basically the idea is remove providers from the middle, keep the rebate and the negotiated price the same, but just make it directly between the manufacturer and the government.
Obviously, we all want drug prices to be lower. The problem is we understand, but it's not fully understood what goes into the launch price of a drug. There are a lot of factors that go into that price. Some of them have to do with the huge discounts that what are known as pharmacy benefit managers that are part of these insurers, or the big discounts that the hospitals gets from a government program called 340B. So there are a lot of things that go into this. And it's very different than other countries where the government is purely setting the price of the drug, and you don't have the influence of the big hospital systems. You don't have the influence of the insurers. You don't have any of that. You literally have the government says, look, if you want to sell this drug here, here's what you're going to price it at. But if you also look at the United States and you look at how quickly we get new drugs and the availability of cancer drugs, there is no comparison to any other country. And again, I'm not defending the price of drugs. And one other thing I want to say, Dr. Mark Fendrick at the University of Michigan has beaten this into me. And he will tell you, and he will say that the price of the drug and the cost of the drug to the individual, to the patient, are in many cases two different things. Because although literally the cost to me as the patient is somehow related to the price of the drug, there are many factors in terms of what my benefit design is, how much I have to pay. So when the average American talks about, oh, I can't afford my drugs, it's not just because of the underlying price of the drug, it's the cost to them. And that's very different. And that plays into this whole idea of the IRA. And you put more pressure on independent oncology practices, and be having a lot different conversation down the road in terms of that being sort of the minority of cancer care as still the majority of cancer care, because the pressures are too great all around, especially coming from the hospital side, to merge.
Ted, one thing that I feel like we hear a lot of, I'm curious your thoughts, is the IRA and these challenges from the IRA that community practices will face are not unique to them, right? Like hospitals will face the same changes in acquisition cost and reimbursement relative to IRA and price negotiation. To me, the difference is that those hospitals have so many more revenue streams and so many more options, and the different, you mentioned like the nonprofit status, et cetera. Like there are these protective factors that make all the difference between them and community oncology, is how I look at it.
Absolutely. You have all their nonprofit status. And back in 1992, this little protective program was created in response to pharmaceutical manufacturers no longer giving out voluntary discounts on their drug because Medicaid best price was created, meaning the best price that a pharmaceutical manufacturer has is what Medicaid gets. And they created this section of a law. It was Section 340B that's become known as the 340B program, that was literally a handful of safety net providers. Now, the majority of not for profit hospitals in this country have 340B discounts. They are at least over 50%. So, a $2,000 drug, they're making $1,000, it's costing them $1,000. And so, even though, as Maddie says, they are susceptible, they will basically get hit as a result. They have a huge cushion and really don't care. So you don't see hospitals balking about the IRA, balking about the effect on them because they have a huge cushion, a cushion of these 340B drug discounts and all of these nonprofit tax benefits.
Someone is paying for this somewhere in a real sense, in a financial sense, but also in a psychological sense. And now I would assume that is all of the individuals with cancer out there.
Let me just say, who's paying for it? You're paying for it. Maddie's paying for it. I'm paying for it in a very real sense. This is something that is costing taxpayers, let alone patients who are footing the bill. So make no mistake, it is literally taxpayers first.
Well, it's tough not to find a little bit of the practice predatory too, because when you talk about oncology, as with many other diseases that threaten people's lives or their quality of life, you mentioned a few minutes ago the cost, right? I think the intrinsic cost to the patient is what you were talking about, and what patient wouldn't ultimately make extraordinary sacrifices financially to keep themselves alive in the situation where they have cancer. So, I mean, you will give up your house, you will give up all kinds of other things. And that's the real downside to all this, right? Is that you're asking some of our most emotionally
vulnerable. It's financial toxicity. So we talk about the toxicity of chemotherapy and the toxicity of the disease. Financial toxicity is real. I can't tell you how many stories I've encountered over my years, Evan, of patients deciding, do I keep the lights on? Do I keep food on the table? Or basically, do I keep my medicine, my treatments flowing? It's heartbreaking in terms of what's out there. And again, I'm not defending the drug companies because they are part of the problem. I even say we're part of the problem. Everybody's part of the problem in terms of trying to make sure that every person in this country, regardless of their status, regardless of their color, their politics, whatever the case may be, has access to quality, affordable, and close to home, accessible cancer care.
So, what can we do? Are there easy things that you would do tomorrow that you think are, I don't want to say bite sized, but we could approach this? Here's a solution here. It may not solve the entire scope of the problem, but at least it addresses a thing. What are some of those solutions that we can be thinking about?
Well, realistically, look, I don't know how, under a number of different administrations, how we basically have allowed all of the mergers that we've allowed in this country, from insurers and their pharmacy benefit managers we talked about. And these pharmacy benefit managers, the top three control 80% of the prescription drugs in this country. How we let that happen, I don't know. But realistically, there is no one going to wave a magic wand and say, we're going to make sure they have to divest. Now, there are some things that are happening, like these pharmacy benefit managers in Arkansas and now in Tennessee, basically to these corporations say, wait a minute, you can't be a pharmacy benefit manager that basically controls 80% of these drugs and have a pharmacy. And I'm not just talking about a brick and mortar pharmacy like a CVS store, Walgreens store, but you can't have a mail order pharmacy that's states away. And so I think more legislation that we actually see happening at the state level. We see a little bit more activity at the state level of coming down on some of the hospital systems and what they need to do, how much money they're making. If you look at Minnesota, the Minnesota Health Department has done a great job of showing how much their hospitals are making on these 340B drugs. I think we need more state activity because, frankly, legislation, which is happening, because, frankly, at the federal level, it's painstakingly very slow. One of the most bipartisan issues, right? Both sides of the aisle, they don't agree on much at all. One of the things they agree on is that the insurance companies and their pharmacy benefit managers are literally fueling healthcare costs. Now, they've done some legislation activity. The FTC is working on some things, even the Department of Labor, and they've passed some legislation. But a lot more has to be done. Actually, more is happening at the state level. So I think more state activity that is happening, more regulation that is happening, because if we don't, this is just going to run out of control. And it's pretty out of control as it is now.
And how about you, Maddie? What do you think? Are there any potential solutions that you've come across or thought about that you feel like might be interesting to explore?
I'd say too, the one that came to mind throughout this recording is people need to know what this situation is. Most people do not understand these concepts that we're talking about, and they might not encounter them. Hopefully, most people don't, but like once they do and they have to navigate these sorts of situations of finding the right care close to home or how to afford their medication, it may be too late to act, right? This is what people are dealing with already. So if more people know, and that's exactly what we're trying to do here, if more people understand how these systems and processes and practice types all influence access to care, I think that's one step.
I would say that we spend a lot of time at COA literally teaching patients, teaching survivors, teaching caregivers, teaching, frankly, oncologists and nurses and pharmacists and staff why they need to advocate, why that some of these, what I would say, wonky bits of legislation are so important. So 2 weeks ago, we had over 100 people, advocates on the Hill in DC in groups talking about some of these issues and explaining how a certain legislation would affect them as a patient or would affect them as a provider of care, a physician, a nurse, or a pharmacist, as the case may be. And it's tough because we have a very complex, convoluted healthcare system in this country. It's kind of like a Rube Goldberg model of healthcare. And it takes a lot of explaining and it takes education to understanding how does this legislation, how do these politics get in the way of me getting access to quality, affordable, accessible cancer care?
The other solution is also just, I think, the willingness to engage with policymakers. And then, even more importantly, the willingness of the policymakers to listen and make changes based on that. And so, when we were talking about IRA and price negotiation, all of the complexities around how drugs are acquired and reimbursed and what that means for downstream pricing and other payers outside of Medicare. I don't think when the legislation was passed, all those things are taken into account. And now it's here, basically. We got a year and a half. It is here. And now that is where the red flags are coming up for the past several years, really. But it's the willingness of CMS to listen to the feedback, I think, is critical. So, for example, we worked with a client on price negotiation and pointing out the limitations of some of the methodologies to get to price. And we ended up seeing the language that the client used in their engagement with CMS in rulemaking. So it's those factors of, we may not agree on how to get there, but to Ted's point, we all want to see healthcare costs go down. But how can we come together, learn from each other, understand the complexities of this system that is just Band-Aid after Band-Aid at this point and really come to a conclusion where we remember that patients are at the center. This cancer care ecosystem is so complex, and I was struck by the thought of you can't have one without the other, meaning community and hospital. However, there is a time and place for both in every patient's journey, and I think that's critical. So where more advanced therapies, or I don't know if advanced is the right word, but these more complex therapies like CAR T, bispecifics, trispecifics, radioligand therapies, where they started in more academic medical centers, hospital centers, as they went through their clinical trials and were approved and more patients had these, and we've generated this real world evidence that these are safe and effective, it creates the opportunity for them to come into the community setting. And I think that's really critical because it offers, for some patients and some of these therapies, cures or more durable therapies at least. And if you can get that closer to home, that's also critical. You know, like initially, if you were getting a CAR T therapy, there was only a handful of centers you could go to. You had to commit to being within a certain distance of that center for a period of time before and after, which is just not sustainable for people who are working, people with families. And now there's an opportunity for it to be close to home. And I think that's really important.
Thank you for talking about potential solutions. If we can close out with a little bit of a vision, what does a better vision, not a perfect one, but what does a better vision for the system and some of the issues that you've described here look like in 1 year, in 2 years, with a different administration, you know, at the helm, or just a different change to some of our politics? What might that look like?
I think the bottom line is that what this looks like is realistically, again, we're not going to slim down the system, but I think we have to have more equitable arrangements in the system. So what do I mean by that? Instead of hospitals being paid here and individual physicians being paid here, what we have to do is this.
Ted, Maddi, I really appreciate it. Very enlightening, a little bit frustrating, but hopefully we can get to some of the places you described, Ted. So thank you.
Absolutely.
Thank you.
Back to John. Now, prior to getting pancreatic cancer, John had spent a lifetime in the ministry. But along with his job, he had to give that up to manage through the cancer. And yet, God had more to say to him. After you've been through the fire, now I'm going to reward you for being faithful, God said. And in 2024, John was asked to be a reverend by St. Galilee Missionary Baptist Church. So now he preaches. He's not only an advocate for patients with cancer, but he's an advocate for faith. John shared his favorite passage from the Bible with me. And since I'm not a reverend, but John is, I'll play you the passage from John himself as he read it to me.
1 Peter chapter 5, verse 10. And the God of all grace, who called you to his eternal glory in Christ, after you have suffered a little while, will himself restore you, make you strong, firm, and steadfast. To him be the power forever and ever. Amen.
Thank you for joining me on Within Reach, a podcast hosted by me, Evan Young, and produced by Avalier Health with the help of Podcast Labs. For more Within Reach content, including in-depth reports about cutting-edge topics in oncology, patient stories, articles, and more, visit withinreach.avalierhealth.com. You'll also be able to meet our SenseMaker experts who have worked hard to bring Within Reach to life. To get in touch, email us at withinreach@avalierhealth.com or follow us on LinkedIn. And who is Avalier Health? Avalier Health is a global strategic partner for the healthcare industry, working across the breadth of the product lifecycle to ensure every patient is identified, treated, supported, and cared for equally. Our advisory, medical, and marketing teams come together powerfully and intentionally to forge unconventional connections, building a future where healthcare is not a barrier and no patient is left behind. If you'd like to support Within Reach, please leave a review on Apple Podcasts or wherever you get your podcasts. Your input helps us make the podcast even better, points us to topics that are relevant to you, and helps us reach new listeners. All you have to do is open up the podcast app on your phone, look for Within Reach, scroll down until you see it, write a review, and tell us what you think. Join me next time as we continue to uncover issues in oncology and work toward their solutions here on Within Reach from Avalier Health.